speakers at the 6th EPUCG 2021, Dr. David J. Shulkin, 9th Secretary of the U.S. Department of Veterans Affairs, USA, Dr. Zeev Lipa, the Lipa Institute of Molecular and Digital Pathology, USA, Dr. Michael Retzke, USA, and Dr. Andreas Lübke, Head of Orthopedic Pathology and Vice Head of Cytopathology, Germany. So thank you very much all. We will now begin with the speaker presentations. So let's start, and I call upon our first speaker, Dr. Liam Bibo, Australia, to deliver his speech. Thank you.
Thank you very much, everybody. I'm just going to share my screen. Hello, everybody. It is my pleasure to be here today to present to you all. My name is Dr. Liam Bibo, and I am a surgical registrar working in Perth, Western Australia. I have a special interest in surgical anatomical pathology, with my topic today being an overlap between the disciplines of breast surgery and gynecologic oncology. The following presentation is of a case of a patient I looked after during my surgical rotation with the breast surgery team last year at a large tertiary hospital here in Perth, Western Australia. I do hope you find it interesting. Primary breast carcinoma can occur at ectopic sites. Primary breast carcinoma of the vulva is an extremely rare entity. Today, I will present a case of labial ductal carcinoma in situ, DCIS, along with a review of the literature. The incidence of ectopic mammary tissue is 1 to 6% of the general population. The axilla is the most common site of ectopic primary breast carcinoma, comprising 91% of cases, but presentation in the vulva is rare. Ectopic breast tissue in the vulva was first described by Hartung in 1872, with the first case of ectopic breast carcinoma in the vulva reported in 1936. While over 90% of vulva malignancies are squamous cell carcinomas, other histologic types include melanomas, basal cell carcinomas, sarcomas, extramammary Paget's disease, and Bartholin gland adenocarcinomas. Although rare, breast tissue arising in the vulva can also have malignant potential. To date, there are 36 cases that have been reported in the literature. Today, I present a rare case of an ectopic primary breast cancer in the form of labial DCIS. A 64-year-old female was referred to the breast cancer multidisciplinary team following excision biopsy of a left labial cyst, diagnosed as ductal carcinoma in situ. The patient gave a history of a vaginal cyst that had been present for the past 6 years and had begun increasing in size, which prompted her presentation for review. The lesion did not cause the patient any pain, and there was no history of bleeding or discharge from the lesion. Her medical history was significant for congenital rubella causing unilateral blindness, ischemic heart disease, percutaneous coronary stenting, and a total hip replacement. She had no history of breast cancer or any other malignancy. Her family history was significant for 2 sisters with breast cancer, both diagnosed before the age of 40. Both were managed with bilateral mastectomies, are still alive, and have previously declined genetic testing. Vaginal examination identified a well-healed wound with no evidence of recurrent disease. There was no inguinal lymphadenopathy. breast examination revealed no significant findings, and there was no axillary lymphadenopathy. Bilateral tomosynthesis of the breasts showed no evidence of breast disease. The patient underwent excisional biopsy of a left labial cyst. So the histopathology, macroscopically, the specimen was a thin-walled cystic lesion, 27 by 20 by 18 millimeters, containing thick brown fluid. Microscopically, the sections showed normal epidermis with an underlying cyst, partly lined by a bland double layer of epithelial and myoepithelial cells. In most areas, the epithelium showed varying degrees of stratification with focal intraluminal papillae, with more complex areas with distinct cribriform architecture. There was mild nuclear atypia with scant mitotic activity, and there was no necrosis in the specimen. No normal anogenital mammary-like glands were identified. The immunohistochemical findings were noted with strong estrogen receptor expression by the epithelial cells and a retained myoepithelial layer. This represented low-grade DCIS. The patient then underwent further treatment, a surgical wide local excision of her left vulva, and examination under anesthesia. The histopathology did not identify any residual disease, along with no clinical evidence of residual disease. The patient was discussed at the breast multidisciplinary meeting, which recommended no further treatments. It was recommended for her to undergo annual breast mammogram surveillance and biannual gynecologic follow-up. The patient remains well and has declined referral to a genetic counsellor for consideration of genetic testing for breast cancer. A review of the literature identified 36 reported cases of primary ectopic breast cancer of the vulva. Of the 36 cases, 22 were of ductal histologic subtype. All cases received variable treatment regimes between types of surgery, radiotherapy, and systemic therapy. Surgery ranged from wide local excision to radical vulvectomy, and sentinel lymph node biopsy to bilateral inguinal lymph node dissection. The majority of patients with a primary breast carcinoma in the vulva have a lymph node metastasis at the time of diagnosis. While the treatment varied considerably between cases, all cases with ductal histologic subtype received at least an ipsilateral sentinel lymph node biopsy and a wide local excision of lesion. There are two proposed theories of how mammary type tissue originates in the vulva. It was first considered to be the caudal remnants along the primitive milk line of ectodermal mammary ridges. The primitive embryonic milk line extends from the axilla to the groin, including the vulva. Ectopic accessory breast tissue can develop if the involution of the mammary ridge is incomplete. Ectopic breast tissue can be found along the milk line as extranumerary nipples, extranumerary nipple areolar complexes, and extranumerary breasts. The most common location of ectopic breast tissue is in the axilla, followed by the area immediately inferior to the normal breast. In addition to these areas, its location in the acromial or scapular region, the vulva, and the midline of the thorax and abdomen has also been rarely reported. More recent studies suggest anogenital mammary-like glands represent a normal constituent of the anogenital area. Nonetheless, both ectopic breast tissue and mammary-like glands are susceptible to the physiologic, dysplastic, and malignant changes seen in normal breast parenchyma. Mainly located in the sulcus between the labia minora and majora, anogenital mammary-like glands are not normally visible, but they are often found in pathological specimens originating from the anogenital area. Their normal histology varies from simple glandular structures with round lumens surrounded by loosely or densely fibrotic stroma, to complex lobular units closely imitating breast tissue. The excretory system is likewise variable. The superficial portion of the excretory duct of anogenital mammary-like glands is rarely sampled in histopathological specimens. It is a peripheral myoepithelial cell layer and luminal columnar epithelium, often showing apocrine secretion. Recognition of these glands is important in the context of cutaneous adnexal tumours. The best approach to the diagnosis of lesions of anogenital mammary-like glands is through the eyes of a breast pathologist, inasmuch as these lesions, benign or malignant, typically show a striking homology to their mammary counterparts, or manifest non-specific epithelial or stromal changes, some of which can be likened to similar changes occurring in a range of benign breast disease. In 1872, Hartung reportedly presented the first case of a fully formed mammary gland in the left labia majus of a 30-year-old woman. Ectopic primary breast cancer of the vulva is rare. The first case of ectopic breast carcinoma in the vulva was reported by Green in 1936. Any of the various histological subtypes of breast cancer may occur in the vulva, including infiltrating ductal, lobular, mucinous, and mixed ductal and lobular carcinomas. On the basis of more recent extensive studies of anogenital mammary-like glands, Van der Put proposed that anogenital mammary-like glands are in fact a normal constituent of the anogenital area. Anogenital mammary-type ductal carcinoma have a marked predilection of the labia majus, rarely involving other anogenital sites. Clinically, they appear as a solitary nodule, mostly in the range of 3 to 4 centimetres. Age at diagnosis has ranged from 46 to 82 years, with most being older than 60 years. A majority of the patients are multiparous. Histologically, most cases are invasive ductal carcinomas, sometimes with an identifiable in situ component, DCIS, featuring cribriform, solid, and comedocarcinoma patterns. Both high-grade and low-grade malignancies exist. The neoplasms express estrogen and progesterone receptors, and their immunophenotype is similar to homologous mammary ductal carcinoma, making difficult the distinction from rare cases of breast carcinoma metastatic to the vulva. Recognition of an in situ component is the best clue to establishing the origin in the skin. Rarely, synchronous vulvar and mammary carcinomas, even bilateral mammary neoplasms, have occurred, suggesting that in some cases, there may be a genetic predisposition. To our knowledge, however, no genetic studies, for example, of BRCA gene mutations, have been performed. Primary carcinomas arising from anogenital mammary-like glands must be distinguished from other cutaneous adnexal carcinomas that may rarely involve the vulva, including hydradenocarcinoma and porocarcinomas, among others. Other mammary type carcinomas. Mammary type lobular carcinoma. This is a very interesting phenomenon, given the well-developed lobular organization seen in the breast is rarely encountered in normal anogenital mammary-like glands. There have been 3 reported cases of invasive lobular carcinoma in the anogenital area. A case depicted cords of relatively uniform neoplastic cells growing in single file, analogous to infiltrating lobular carcinoma of the breast, with areas of ductal differentiation. This case, however, is a likely example of mixed ductal and lobular carcinoma. In the breast, the criteria for the diagnosis of a carcinoma with a mixed ductal and lobular features include an appropriate histological appearance supported by immunostaining for E-cadherin, which is positive in ductal carcinoma, negative in lobular carcinoma. As in the breast, such cases should be distinguished from tubulolobular carcinoma. For a diagnosis of this disease, a thorough metastatic workup should be performed, with attention directed towards detecting a primary breast cancer by the results of the history, physical examination, and radiologic examination of the breasts to confirm that the vulvar lesion is the primary site, as opposed to a metastasis from a primary breast cancer. The possible rare association of these lesions with synchronous or metachronous breast cancers, of which there are 16 cases in the literature, makes the exclusion of breast lesions an important part of management. Irvin et al. Defined the criteria for diagnosing this disease. When an in situ component is not present, in the absence of concurrent breast carcinoma, the following should be sufficient to categorize the lesion of primary vulvar origin. Firstly, a morphologic pattern consistent with breast carcinoma. 2, the presence of estrogen and progesterone receptors. And or 3, positivity for common breast cancer markers such as epithelial membrane antigen, carcinoembryonic antigen, and glandular keratins. Primary breast cancer arising from either embryonic mammary remnants or anogenital mammary-like glands is an extremely rare histologic subtype of vulvar cancer. Diagnosis rests on the pathologic findings with recognition of the characteristic histological features and the presence of estrogen and or progesterone receptors after the possibility of metastatic disease from the breast primary cancer has been ruled out. Therapy should consist of an individualized combination of surgery, radiotherapy, chemotherapy, anti-estrogen therapy, and monoclonal antibody therapy, similar to cancer of the orthotopic breast of similar stage. Lymph node pathologic status is the most important prognostic factor in vulvar cancer. Owing to the rarity of these lesions, clinical trials to determine optimum treatment are not available, and management guidelines rely on small case series or case studies. So the learning points that I've taken away from this case. In most cases, surgical treatment of primary ectopic breast carcinoma of the vulva includes surgical excision with inguinal lymph node dissection. Vulvar cancer is ideally suited for sentinel lymph node mapping, secondary to the predictable lymphatic drainage of the vulva, the low false positive rate, and the substantially reduced morbidity compared to a full groin lymph node dissection. Sentinel lymph node dissection could be considered an effective alternative to lymph node dissection. Because of the rarity of the diagnosis and the lack of definitive treatment guidelines, this type of cancer is currently staged and treated according to the tumor node metastases, TNM based classification, applicable to primary breast cancer. Patient shared care between breast surgery and gynecological oncology is recommended. In this case presented, the patient was first managed with an excisional biopsy. Following the pathological diagnosis of vulvar DCIS, the patient then underwent a vulvar wide local excision, which showed no evidence of recurrent disease. Future treatment with endocrine therapy remains an option if there is recurrence of her disease, given the strong estrogen receptor expression of her cancer. This case report highlights the rarity of vulvar ductal carcinoma in situ. Thank you very much. I would now welcome any questions.
So first of all, thank you, Dr. Liam Bibo, for your valuable contribution and comprehensive speech. Are there any questions from the audience? Well, I think you covered all questions.
Thank you very much for having me.
Yes, thanks for your contribution. Well, that happens sometimes, that the quality of the presentations is that well that everybody understands what you would try to conduct to us. So, by the way, a very good morning to everyone. I will continue with sharing this session. My name is Andreas Lübke from the University Medical Center Hamburg-Eppendorf in Germany. And yeah, I had some technical